Baska Kurushotam. I hope I pronounce it correctly. Safety and short-term hemodynamic and clinical efficacy of Penumbra Indigo Light in Flash System for immunoglobulization. Intermediate. Thank you. Thank you for the opportunity. So that's the title of my talk. I'm a consultant and a speaker for Penumbra. So we've seen in the last few years, at least in the last 5-10 years, a lot of plethora of devices in the treatment of PE mechanical thrombectomy. So far, there's no published data on the use of Oliver Flash system. The STRIDE-P study did present that 86 patient subset of Flash 1.0 at TCD in 2024. But as far as the Flash 2.0 catheter goes, there is no current data anywhere. And I think it's very important to move the dial because the mortality in intermediate risk PE in the 30 days is 7 to 14%, and nothing's happened in the last 20 years. So with this study, it's a retrospective study, and I just wanted to see how safe is this device and how efficacious it was using both the Flash 1.0 and the 2.0. So single center, single operator. So we looked at patients from June 23 all the way to end of last year. And up until May last year, we used close to 5 of these Flash 1.0. And then later on, we started to use more and more. It's very similar. As you get more familiar and more comfortable using these devices, you get better at it with better outcomes. So the Flash 2.0, essentially they made simple with very simplified audible and visual cues. And the idea was to improve the procedure time, reduce the blood loss, and make it a lot more simple to use it. So if you look at my baseline characteristics, I told you 15 patients, perhaps them had multiple medical comorbidities. These were medications. So one of them was on rivaroxaban and developed a PE on that. Most of the patients presented were either 2 to 3 days history of shortness of breath. We had a few patients who presented with shortness of breath and the syncopal event. So when you risk stratify these PEs, as you know, low, intermediate, and high end, the intermediate risk, we had 10 of them with intermediate high risk, that's essentially with the esv2 score, which is elevated, with RB dysfunction and a troponin elevation. So these were the presentation hemodynamics. Except for the blood pressure, everything is on the high-risk side. So this is the other key factors. So esv2 score of any kind greater than 1 is considered a 1 or above is intermediate risk. Modified Miller Index, that's the volume of thrombus. If it's 16 is the worst, 11 is what we had. All our patients had RV-LV ratio greater than 1. And obviously by echocardiography, these patients had high risk. And we also had a regular normal IDF. So I want to do a case presentation. 67-year-old gentleman, the shortness of breath leading to a syncopal event, all the features of intermediate high-risk PE. So this is his CAT scan. As you can notice here, of the saddle embolus filling both the pulmonary arteries, and then you focus your eye right here on the RV, you can see it's twice the size of the LV. This is the echocardiogram, and this is the right ventricle, and you can see it's twice the size, not moving really well. The typical McConnell's sign. See, based on the PA pressures, I take a quick pulmonary angiogram, and then so I use this. This is the sheet, the bore sheet. It's 65 centimeters, sits there, and that's the Penumbra Cat 16 catheter. And I tend to use the separate a lot for a lot of reasons. One is it acts as a rail. Number two, it acts like a pilot wire, and if it moves, still feel the size of the vessel, so I know how deep I can, advance the catheter. So this was the thrombus aspirated with just 2 runs. These were the final finish angiograms. The good thing with these, I will not achieve picture-perfect results, and I look for symptom improvement and changes in hemodynamics and pulse oximetry. So remarkably, the very next day, you had significant improvement in the RV function and size, and on follow-up, and we saw him 6 weeks later, he's doing really phenomenal. So going back to our patients, so this was our procedural details, this 15-patient cohort. From the time of local anesthesia to closure, 54 minutes, contrast use, blood loss is 450 cc average, but as we got better with this, especially the Flash 2.0, our valuing is less than 400. We achieved technical success in everybody except one patient. Had no changes, and I suspect most likely the patient had chronic PTs. Nobody had any interprocedural complications. And I do this with very minimal sedation because RV is very dependent on preload. None of these patients received the blood transfusion, and the duration of hospital stay was under 3 days.
with ICU stay with one patient who had persisting CHF for 2 days. So this is the big difference with the flash tool. Procedure time is reduced, blood loss 30 years in a day, no anti-procedural complications. Here's the pulse oximetry, which includes just before I start the procedure to questionation. A lot of these two procedure bases were on supplemental oxygen, and a good number of them came off it. But yeah, this is interprocedurally where I measure with the PA catheter, significant improvement in the paper. This is the criteria. They say procedure, they will on follow-up. It's almost normalizes, and this is the RV function. So scales up there, and most of them pretty much normalized. In similarly with the RV science. So 6 weeks follow-up, the 12 patients are complete resolution of symptoms, one day down and through, which we talk about. A couple of them had some leftover symptoms, but the RB parameters, all of them completely input. Obviously, it's a single center study, but so far there's no data on 2.0 and nothing is being published still. But it's reassuring to know that, we got similar results in a real set and hospital. So I think end of the day, this is for the safe capital. The 2.0 period is very simple weaker. So far, there are no adverse events. No remedy season definitely reduces the hospital stay. It with an excellent clinical and hemodynamic replacement. And I test them that the tip-toe separator really helps me with the results.
Pastor, very nice presentation, and again, good to see single-study data, especially as he said, South Dakota. In a real setting, having E there is did say this to the cases there, and thanks to the presentation. But a couple of questions: are you a part of Strike PE trial or no?
No, they're not.
Okay, all right. That's an ongoing trial.
Yeah.
With 2.0. So when I'm looking at your data, you had a nice pie chart with the intermediate lows and intermediate highs. What led you to do an intervention in the intermediate low risk?
So we're seeing that we follow these patients in the tenet that to be resident mechanic thrombectomy. In good 33 to 40% had significant post-PEs. And so, I've been talking to friends around the country, and they've been offering, especially the younger patients, large volume thrombus, which can be easily accessed with a catheter with RV response, and they've had significant improvement. Also, when you look at studies being it, he's been based on these procedures. So, we decided to offer and cop in these spaces about.
So what I hear is, for intermediate low risk patients, it's younger patients you think that are at low risk from mechanical thrombectomy and for complications we can palliate the procedure, and the ultimate goal is to reduce the post-PE syndrome.
Yes.
Okay. All right. Good. Any other questions from the audience?